So thank you again to Michael and to our panel, Don, Amelia, Liz, and Bill. And Don, I hope you're able to get at least a couple days off around Thanksgiving and Christmas. That was a great conversation, a great discussion. Before I turn it over to Brian O'Grady from CDPHP to introduce the next panel and help us with our discussion on really the affordability question, in case you haven't opened them, this is our gift to all of you today, and I think is timely considering the conversation we're about to have about affordability, sort of the question of what does it cost. So this will certainly be, I think, a timely and topical conversation. Katie's going to have some great information about what's going on with cost, but with that, let me turn it over to Brian to introduce our panel. Brian?
Thanks, Eric, and good morning, everyone. I want to take a quick minute to introduce our panelists. But so our next session is on the challenge of affordability for care, costs, and coverage. So our panelists are on the stage. I'll introduce them, and Katie will give us a brief presentation. She's going to throw a lot of information at you. So once again, remind you those note cards in the middle of your table are for you to jot down questions, thoughts that come to your mind during Katie's presentation that we can revisit during the panel discussion afterwards. So as I introduce you, please just note which one you are, so we're already on stage. So we're going to start with Katie Martin. She's the president and CEO of Healthcare Cost Institute. And Katie sets the organization's strategic direction, overseeing its research agenda and making HCCI's best-in-class multi-payer claims data set available to leading academic and policy researchers. Before joining HCCI, Katie was the Vice President for Health Policy and Programs at the National Partnership for Women and Families, and also served in the federal government at both OMB and Department of Health and Human Services. Also with us is Cora Upsall, Director of 32BJ Health Fund, which is a self-funded health plan that provides affordable, comprehensive, and innovative health coverage for over 200,000 union employees, members, and their families. In her time with the Health Fund, Cora has led the implementation of multiple benefit changes, including some rather difficult ones, removing New York Presbyterian Hospital System and the physicians from their network, transitioning to a new pharmacy vendor and pharmacy group purchasing coalition, and implementing an expanded Centers of Excellence program administered by Mount Sinai Hospital System. Prior to joining the fund, Cora spent 12 years with Express Scripts. Also with us is Erica Stocker. Erica is the Vice President of Healthcare Arnold Ventures, where she leads commercial sector pricing, provider payment reform, and Medicare sustainability portfolios. Prior to joining Arnold Ventures, Erica worked at the White House, OMB, where she led the Health Division's quantitative work to advance policies for the President's budget, federal regulations, and legislative proposals, particularly those proposals related to the Affordable Care Act. Prior to joining Arnold Ventures, Erica, I already said that, I'm duplicating a paragraph. So, and finally is Wendy Stark, and Wendy is the President and CEO of Planned Parenthood of Greater New York. Wendy recently joined the organization in October. Previously, she served as Executive Director at Callan Lord Community Health Center, where she was instrumental in the growth of the organization, doubling its healthcare capacity and expanding its geographical presence. Under Wendy's leadership, the organization started a formal research and education program to advance LGBTQ+ health data, as well as policy and advocacy programs to work toward health equity, and justice. I want to welcome all the panelists. As we said, I'm going to turn this over to Katie for a presentation. Once again, questions will be welcomed. We've got questions, but also always want to entertain questions from the audience as well. So, Katie, I'll turn it over to you.
Great, thank you. Good morning, everybody. It's so nice to be with you this morning. Get ready for a high energy panel, because what doesn't get a room moving like math and charts and graphs and numbers? So like I said, my name, or as he said, I'm Katie Martin. I'm the President and CEO of the Healthcare Cost Institute. Really happy to be with you this morning. I am a native of Syracuse, New York, so any chance to come to the Erie Canal region is very much welcome. So the Healthcare Cost Institute is a nonprofit, nonpartisan organization in DC, and our mission is to use data, research, and policy expertise to give decision makers the tools they need to make the U.S. healthcare system work better, and that covers a wide variety of things. In my presentation today, I'm going to share with you a few things. One, yes, healthcare costs are a problem. Two, you know why, but I will confirm for you why. 3, there are lots of things we can do about it. And 4, I'm going to end with a random movie quote and analogy. So edge of your seats. I do want to say a couple of things about the data that I'm going to present. The data I'm going to present is on the employer-sponsored insurance market, so it doesn't cover Medicare, Medicaid, the individual market, et cetera. As we consider healthcare costs and affordability, we also need to consider people who are uninsured, people who are underinsured, and we also need to remember that there are other really critical healthcare goals that we're trying to achieve, whether it be health equity, access, et cetera. So what I'm talking about is a narrow scope in some ways, but because employer-sponsored insurance covers more than half of the U.S. population, I do think it is a fair bellwether for what's going on with healthcare costs and spending. As you all know, claims data is notoriously time-lagged, so what I'm going to present is 2020 data. We're working on ingesting our 2021 data now, but I actually think having 2020 data is really helpful and informative because that was a real interesting year for health policy. And my thesis is, which I think is borne out in the data, is that despite this shock to the healthcare system that we collectively experienced, what we see in terms of healthcare costs and healthcare drivers are actually pretty similar. So with those caveats aside, what are we seeing? So in 2020, per person healthcare spending among people with ESI was over $5,600. From 2019 to 2020, we saw a 4% decrease in spending, which is the first time we've ever seen a decrease in spending in the 12 years we've been doing this report. Obviously, it was COVID related. It was driven entirely by a decrease in utilization, which we'll see. But the point I want to make for you is there are 2 points I want to make. One is that leading up to 2020, healthcare costs and healthcare spending were growing at a rate of 22%, and then it kind of fell off that cliff in 2020. And that even though that cliff happened, healthcare spending in 2020 was still 9% higher than it was in 2016. So we're still seeing cost growth. The pandemic did not fundamentally shake or move anything that we had seen in trends to date. This is a doozy. Bear with me. Here's the point. It's happening across the healthcare system, but here's what's really important. On the left panel, the solid rainbow lines represent price, the dotted rainbow lines represent utilization, and then they come together for spending on the right. So the 2 main points here are that it's the trends that we're seeing are pretty universal across healthcare in inpatient, outpatient, and professional services. Prescription drugs are a little bit different in that we didn't see the decline in spending, but that also should match with your intuition. It wouldn't be as affected by the pandemic as some other services. But notably, price is going up all the way along. Like there's not a point at which prices are like, whoop, our bad, we'll come back. So it's a lot to take in, but that's sort of what the put and take is of that side. So COVID and 2020, among the reasons that I feel like COVID is not kind of the shape shifter or ground shifter that you might have expected is because the decrease in spending that we saw was really limited to the early months of the pandemic. What this graph shows is healthcare spending in 2020 for a month in 2020 compared to that same month in 2019. And so the big dips you see in March, April, and May are really the decline in spending in those early months of the pandemic. What I actually want you to pay more attention to is June and beyond, where the decrease in spending in 2020 has gone away. So the fact that I'm still observing a decrease in spending in 2020 compared to 2019 means that dip, that early month dip, was pretty substantial, but it also comes back pretty quickly. And I think that's important for considering kind of how to think about the rapidly changing environment we're in now. Don't worry about these. I'm going to flash through them real quick. But basically what this shows is for inpatient admissions, it performs exactly as you would expect. The use of musculoskeletal circulatory admissions go down, childbirths generally stay flat, respiratory admissions go up. It's a similar pattern in outpatient stays. Procedures fall off a cliff, physician services mostly decrease. Telehealth's use, which we'll come back to, is off the charts increasing. That is in very large part reflective of the change in policy that happened in 2020. But when you take a step back and say, okay, that was a lot of graphs, Katie, and maybe you should dial that back next time, noted. But here's what I think it says, that with all those moving pieces and parts, when you compare what the healthcare dollar was spent on in 2016 to what was spent on in 2020, it's mostly the same. we're still spending about the same proportion on prescription drugs, on inpatient, on outpatient, and on professional services. So again, I think the evidence suggests that despite this really epic shock to the healthcare system, healthcare costs and healthcare spending are kind of the same. We have a project at HCCI called the Healthy Marketplace Index, where we compare spending in metro areas against the national median. And in that project, we found that high-spending metro areas in 2020 were the same high-spending metro areas in 2019, and that pattern held particularly true in prices. So if you had a metro area that was high-priced relative to the national median in 2020, it was a high-priced national median in 2019. So we didn't see a huge shift or move in healthcare costs or spending even among metro areas. So I would be remiss to come to New York and not talk about New York. Panel on the left is the one you've seen before. The panel on the right is using New York State data. So for the employer-sponsored insurance population, New York State spending was $6,600 compared to $5,600 nationally. Notably, the patterns of the lines are pretty similar, though I think it's important to highlight that the price line is substantially growing at a much higher rate than nationally. It's also really interesting to me that the dip in utilization was not as high as, or can a dip be high? The decrease wasn't as dramatic as it was nationally. This is the confusing graph. This is the components of the confusing graph for New York State. All you need to take away is that the lines are a little bit different, but the patterns are very much the same. Prices continue to go up, utilization either stays flat or has this interesting COVID dip. And so while New York is special and different, it's not immune from whatever the cost trends are that are driving nationally. So to kind of bring this point home, relative to the national median, spending in New York State, statewide, we find is 14% higher. It's driven by 24% higher use of services, 9% higher prices, which are offsetting a lower mix of services, which is just a way of saying that people in New York State are probably using less intense or less expensive services compared to nationally. Because I grew up in Syracuse, I know that New York isn't New York, and so I just included here some comparisons to New York City, where overall spending is 20% higher than the national median, and Syracuse, which is 8% below. And you can break that down by price, use, and case mix. So in the city, it is both higher than national median prices, higher than national median use. In Syracuse, there's slightly lower than the national median price, but higher than the national median utilization. And we have the same data for Albany, Binghamton, Buffalo, Rochester, and Utica. And so all of it is just, well, hold this thought. Remember this graph later with the movie quote. Okay, so great. I could have saved us all a lot of trouble. You have a t-shirt on your table that says the same thing. Healthcare is expensive, costs are expensive. It's different across parts of New York State. But why is that? So it's mostly because of prices, and it's because of prices, and then also it's because of prices. So the things I want you to take away from this slide are that despite the pandemic and despite everything else, prices continue to grow from 2016 to 2020. Asterisk. A lot of the rates were negotiated well before 2020. Maybe prices will catch up. Maybe it will be different in 2021 or 2022. You all could probably tell me that better than my data can. It's also possible that in the age of the pandemic, the people who were seeking services were more complicated, seeking more complex care. All of that is captured in our price line, but it is also unit prices. And we've done a little bit of analysis to see, like, is this really just a COVID thing and prices actually decreased or were flat? Reader, they did not. Looking forward, I know what is top of mind to all of you is likely inflation, and certainly it is the case that inflation will affect input costs that will increase prices. I also think it is the case that inflation will spark a conversation about prices that might not otherwise happen, irrespective of the actual impact. I think providers will use it as an opportunity to negotiate rates. I think you all can use it as an opportunity to say, well, speaking of prices, let's revisit that. And I think the government will take the opportunity to look at policies to to control prices, given that inflation will just put upward pressure. But in the end, as I said, it is really unit prices. It is the hardest nut to crack in healthcare and health policy, but it is the most important and most significant driver. If we look internationally, the U.S. has higher prices than other countries, consistently the highest for inpatient admissions, for brand name drugs, of interest not always for generic drugs and not for outpatient services. This is a lot of graphs, same thing. Here's what I want you to focus on in the next couple slides. Our orange, reddish lines. As a note, HCCI's brand colors are orange and blue, and it is just a happy coincidence that I'm from Syracuse. Anyway, so what I want you to note is that the orange lines always go up. No matter what I flash here, the orange line always goes up, always. So that's cool. Prices are up. We don't have a great policy intervention to solve that, so what are we supposed to do? The next few slides I'm going to show you talk about how to take what can be kind of a macro, overwhelming problem and break it into bite-sized pieces. So we've done a lot of analysis to look at things like where do we see prices playing a particular role, and one of them is site of service. So we did an analysis that looked at the exact same service in an outpatient setting versus an office setting, and we found that the outpatient price was always higher, and clearly magnitudes higher. Everything from biopsy to ultrasound, in an outpatient setting, it costs more money. We more recently looked at lab tests. We've tried to think of what is the service that is truly identical, that you can't really make a quality argument. And so we were like, lab tests, let's take a look. And when we did, we found that the median price for a lab test that was conducted in an outpatient setting was 3 times the price in an inpatient, in a professional setting or in an independent lab. It was true across all lab tests. It was true across all categories of lab tests. It was true for individual lab tests. So clearly this is an area where a lot of policy attention should be focused, and where I think you all as payers have a real opportunity to exert some pressure on pricing. Administered drugs is another area. There has thankfully been a lot of attention on prescription drugs, and I think that's important and critical. But administered drugs is an area where we're seeing a lot of price increases. You see relatively stable utilization, but prices are going up, and they're going up pretty dramatically. And they are going up differentially in the outpatient setting versus an office setting. So this is an area that deserves and requires a lot of policy attention, and I think because they get folded into other services, folks don't always pay quite as much attention to them as they do to prescription drugs. There also is a lot going on in the world and in policy that will affect utilization. Telehealth is a good example of this, and I think this is really the $64,000 question about, so what about telehealth? There's so much promise and potential for it to be cost-saving and cost-effective, but the question is, will it substitute for in-person care, or will it be a complement to it? As I said, we saw literally off-the-charts growth in spending. A 250% increase in spending is unlike anything we've ever seen before, and that is generated from a 120% increase in use. The chart on the right maps telehealth, which is the blue line, against in-person physician office visits and non-physician office visits from January 2019 through December of 2020, and you can see the spike in the early months of the pandemic, which corresponds with the dip in in-person visits, and then they reverse, but they don't exactly reverse. So there's lots to pay attention to there, and I think like with most things in health policy, if you don't set explicit goals and objectives, any intervention will get away from you. So I think there's still a lot of questions about how to structure telehealth policy and telehealth use in a way that is cost effective, that promotes equity, et cetera. Obviously, there was also a decrease in preventive services and access to services in the pandemic that have the potential to delay or defer care such that costs will go up in the future. The chart on the left shows mammography rates in 2020 compared to the preceding or the same month in the previous year. And the one on the right is vaccination rates. And so it's worth focusing on what that dip in preventive services will mean longer term. And then I also think that a lot of the pieces of what's going on in politics and society that were discussed in the first panel have the potential to have an impact on healthcare costs and spending. We did a study on firearm injury and the impact on health spending and found that in the year post-injury, healthcare spending on those folks was more than double what it was pre-injury, even when you take out the actual treatment for the injury itself. Clearly, the human impact and the human toll of gun violence is much more important than healthcare spending, but I do think as a healthcare community, it's important to talk about the way that it affects the system as well. And then the graph on the right is a study we did on inpatient admissions among children, and it found that mental health was the primary reason for childhood hospitalizations, aside from being born. And that was true even before the pandemic, but certainly increased in 2020. So the other, I'm shifting now in my mind to kind of like, well, what do we do about it and where do we focus? And I want to talk a little bit about hospitals. So hospital spending, when you add up the actual facility fees plus the professional services, makes up more than half of the per person spending dollar. And anything that takes up half of our per person spending dollar, we should be paying attention to. And certainly consolidation is an area that is driving that cost up, but I also think it is worth looking across the board at hospital spending in the same way that society has historically looked askance at prescription drug spending. I think it's time to start looking at hospital spending in the same way. You can play around with this much more on our website. The chart on the left shows market concentration over time from 2016 to 2020. The green lines that are shooting to the right are markets that are becoming more concentrated. And then the map on the right shows the scale from competitive to concentrated markets by metro areas. All right, well, that's a bummer. So what do we do? I don't know, but I think we can figure some things out. So certainly among the ideas that come up is price regulation, price setting. What do we do about prices? The OECD has this nice spectrum of individual negotiation to unilateral administrative price setting, which the US has both of. I think a lot falls on you all because we don't do a lot of price regulation and price setting. And so it's really you all who are front and center of these negotiations with providers to do the heavy lifting for the rest of us. Thank you. But really it's like it's a one-on-one retail negotiation to explore why are your prices so high, what's going on there. I would be remiss to say that, to not say that the financial incentives in the system are what make prices what they are. And so we really need as much intervention as possible to try to bring them under control. From a policy perspective, there's a lot that can be done, everything from increasing price transparency to capping prices. The Congressional Budget Office just did a report that looks at each of these and quantifies the impact. It is certainly the case that increasing price transparency will not have the same impact as setting a price. I do think that it is a necessary precondition to everything else that happens. We can't know how to control prices or to intervene in healthcare costs if we don't actually know what the price is or how the money is flowing through the system. So I wouldn't want you to be discouraged and say, meh, price transparency has a small impact, so let's not do it. I just think it's the first domino that has to fall for some of these other pieces to come through. And then certainly any policy that promotes competition, whether it's antitrust enforcement or Medicare incentives, is also an important component to this puzzle as well. Okay, so I promised you a movie quote and I haven't used it yet. Okay, how many of you have seen the movie City Slickers? Okay, so there's an old grizzled cowboy who has the secret of life, and he is talking to Billy Crystal about what the secret of life is, and he says it's one thing. It's just one thing. And so what I would say to you is, what can you do about healthcare prices? It's one thing. It's only one thing. What am I talking about? So the punchline of the movie in City Slickers is the one thing is different for everyone. Whatever your secret of life is to be determined by you. My secret of life isn't the same as my panelists, et cetera. The analogy in my mind is do anything about healthcare costs. Literally anything, because there isn't a single thing that we can do that can solve the problem on its own. So for you personally, or for you as a company, if anything that I've said to you really resonates, or you feel like you have a particular advantage or an edge or an interest in one of those things, do that thing. Let's just not do nothing. So find your one thing. Let's become the grizzled cowboys of healthcare costs and figure out what the one thing is that we can do. And like, if you can do 3, that's also cool. But there isn't a silver bullet at all. And there's just lots of different ways to apply pressure. And I think the smaller and incremental changes and really starting to chip away will be ultimately what leads to success. So thank you all for your time. Appreciate it. And I'm looking forward to the discussion.
I want to remind everyone of the cards on your tables. So if you have questions based on Katie's presentation, please make sure you get them up to us. So I'm going to start at the far end with Erica.
Okay.
So I think one of the last few slides was on hospital consolidation, healthcare system consolidation. It accounts for 55% of our spend right now. So when we look at that, and they often argue that that transition is, and those transactions are necessary to become more effective and efficient. So is that actually occurring? And are there approaches that you suggest that would ensure that these consolidations don't lead to higher prices?
Yeah, thank you, Brian. So I would say that, so what hospitals will typically argue is that we need financial integration to lead to clinical integration that results in better outcomes for patients, which is what we all really care about in the end. I don't think the evidence supports that that is happening at all. There are a lot of places in the economics literature where you can kind of look around and different people are saying different things, and that's not the case here. The evidence is very clear that hospital mergers and horizontal consolidation leads to higher prices, and that we don't see quality gains, and then in some cases there's evidence that quality actually declines when hospital systems merge. We see a similar story with vertical integration, where hospitals are purchasing physician practices. This is happening more and more, and we see that that is resulting in higher prices for physician services and for outpatient services as well. And so I think to the extent that these efficiency gains are happening, and I think there's reasons to doubt that, that's not flowing through in any meaningful way to lower costs for people or to better quality care for people. So I think the question then is what we do about that. We can, one kind of bucket of solutions is stopping further consolidation from happening. I think that we should do that where we can. I think vertical integration is a real place to look, since that is something that's happening now, and some of the consolidation that's happening with private equity entry. But in a lot of the market, like, the problem is pretty far gone. And as Katie showed, like, we have very consolidated hospital markets in a lot of places. And so then I think we're looking at a couple of different types of solutions. One is kind of policies that go like directly at tactics that dominant systems are using to drive up prices. So things like banning anti-competitive provisions that they're using in contracting. So like anti-steering, anti-tiering that like prevents you from creating high-value, low-cost networks and affordable products for your enrollees. And I think there's some cases where we need to be talking more directly, as Katie mentioned, about directly limiting prices in some way, whether that's through like cost growth benchmarks at the state level or capping prices and like the maximum amount that can be charged in some way. But I think the main thing is on the policy solution, like the cat's kind of out of the bag here. We have a lot of consolidation, even in markets that like the FTC wouldn't consider highly consolidated. We still see a lot of really excessive prices. And so policies that kind of more directly limit those, I think, are really going to be necessary in the end.
Maybe experiencing technical difficulties. Yeah, it's on. You can't hear me very well? Oh, yeah. I'll lean over and the window.
Should I quote more movies? I have a
Keep going.
whole catalog.
All right, is that better? Is that better? Small? Oh, you're on something, so thank you. All right. I don't know if that's any better. Can everybody hear me? All right. Oh, I can. Yeah, that's a lot better. Or worse. So, so thanks, Erica. So, Corey, I'm going to throw it to you now. You made some big moves for the fund with not only, pharmacy benefit purchasing coalition, but PBM, but also, taking Presbyterian right out of the network. So tell us how that went, the decisions around that, and then what was the acceptance by the membership, and how did you drive that behavior change throughout your membership?
So, excellent question. I will answer your question. I just want to actually comment on Katie's presentation really quickly first. I think that you hit the nail on the head that related to the impact of pricing. And that I think the thing is that for most of us in the room, this might be old information, or at least in theory, we should all know this. I think what people don't know is that when it comes down to the employer side of things. And as the employer, most employers don't necessarily know what their looks like. They're not getting their claims data. They're not getting, and now under the CAA, they have access to their claims data. But then once you get it, how do you use it? And so I know the question is, what was the impact of Presby? But I think the important part first is that we used our data. We've had access to our data for years, which allowed us to really understand how are we spending our money. We're a self-funded plan. Katie, your data was all about employer-sponsored insurance. These are self-funded plans who are entrusting the health insurance companies here in this room to be good stewards of their dollars. But I would challenge that it actually has to be the employer who has to start to really understand how to be good stewards of your dollars. It's really what led us to removing New York Presbyterian, their entire hospital system, and all affiliated physicians, not just employed physicians, but affiliated physicians from our network. It impacted over 25,000 of our members who had used a New York Presbyterian hospital or affiliated physician in the last 2 years. And we said, you know what? We understand that removing access is a big deal. But the reality was the cost savings that I got because of their high prices, not just because they cost more, but they charge more. And in part of it is because of their anti-competitive practices. We can talk a lot about what, the conversation started with the President of the Senate speaking related to HEAL that was passed this year. But that only included 2 of the original 5 provisions because the Greater New York Hospital Association did not want to remove anti-competitive practices such as anti-tiering and anti-steering provisions. And, it's important to say that because I think these are real things that hinder the ability of employers to be able to make our own benefit decisions. Luckily, I think we ended up with we have a strong partner with our third-party administrator who helped us be able to remove New York Presbyterian. And the impact is profound for us. We anticipate we will save over $30 million this year alone from removing them from the network. And $30 million bottom line matters to me, but as a health fund for a union, it matters to our members. This savings resulted in assisting in the residential real estate contract that was up in April. That resulted in a $3,000 bonus to all of our residential real estate workers, the largest wage increase in the history of the contract. And then I think the other piece that's really important is that for the employers, we're holding their premium increase to only 3% in 2024 and 2025. That these types of things that we're able to do have direct results to our employees, to the employers who are funding it. And I think that's important because it's easy to talk about, it saves your bottom line, because it is, but it goes back down to the members get more money in their pocket. And I think that sometimes we miss that conversation point when we talk through these things.
Great, thank you. Anyone else have a comment on that before I ask Wendy a question? So, Wendy, can you talk a little bit about how increasing prices impact the access to women's care? And in addition, does this provider consolidation that we're talking about right now, what kind of impact does that have on Planned Parenthood, and what type of actions do you take to kind of combat that?
Sure, thank you. Is that working? Okay, one moment.
Is it on the top?
Okay, there we go. Okay, let's try again. There we go. So let me talk about the consolidation part of that question first. Am I mic'd? Not so much. Okay, there we go. So Planned Parenthood of Greater New York specifically covers 65% of the geography of New York State in its clinical sites. And so we're talking about everything from Nassau County up into the Southern Finger Lakes, although there are other Planned Parenthood affiliates, as they're called, right throughout the state. And consolidation has had a very different impact in different parts of the state in some ways. So in our more rural counties where there's been consolidation that results in the only local providers or health systems being Catholic health systems that don't actually provide the kind of sexual and reproductive health care that our patients are looking for, then we have tremendous access problems and really differential access to care because of the politicized, stigmatized nature of some of these services. So that's a very different issue in some ways that relates to consolidation, but a very profound one that we're seeing in places like Amsterdam, New York, and Newburgh, and other communities in the more upstate or Western New York region. And then we have the issue of part of consolidation, of course, was meant to be for price leveraging, for negotiation purposes with, the folks in this room. And I think what it did is in similar ways to how we see sort of the distribution of wealth in this country happening, we see that in healthcare, right? And so the smaller healthcare players, and Planned Parenthood among them, and the federally qualified health center that I last worked at among them, we don't have the kind of volume, even though we're providing very specialized services in sometimes to particularly medically underserved communities, or services that won't be provided by other providers. But we don't have the kind of volume and lives that let us come to the table in particular ways around reimbursement. And so we're constantly looking for ways to subsidize the care we're providing. And dissimilar to larger healthcare systems that are providing more vertical services, we don't have loss leaders, right? So we're not doing outpatient care because it's a loss leader for different kinds of procedures or inpatient care, as the case may be. We don't have that. And so all of the services we provide to some extent require subsidy at the end of the day if we want to be a competitive employer in today's wage environment, and an ethical employer in today's in the wage environment, right? Fixed costs for us as smaller healthcare institutions are rising in the same way. We have the same tech sort of cost increases, not at the same scale, of course. Real estate, right? In those hospital consolidations in communities that are creating lack of access because of the stigmatized nature of parts of our care, we're also seeing real estate being sort of gobbled up by those health systems, and then our access to even space, bricks and mortar to provide our care is limited. And so there are sort of these domino effects that I don't think get captured in the same way in the data, for very good reasons, that are unanticipated. I think they're unintended consequences of some of this, but they're real consequences to healthcare access to our communities.
Thank you. Thanks. So, Katie, you talked price, right? And some of the factors leading to kind of the price increases in the market are market clout, site of service, and case mix in some cases. But can you talk a little bit about how the payer mix contributes to the provider systems and the hospital systems, demanding more price? So the percentage of their Medicare or Medicaid population, and what that then impact that has on the commercial insurance and the commercial rates?
Sure. So I think it's a really good question, and this question about cost shifting comes up quite a bit. And I think multiple things are true at the same time. I think it is the case that providers do take into consideration the mix of payers as they set prices for the different payers. But of course, Medicare sets the price, so there's no negotiation on that front. There does seem to be pretty clear evidence that cost shifting in a real technical sense does not happen, in the sense that a decrease in a Medicare price is not automatically associated with an increase, or really more to the point, an increase in a Medicare price is not associated with a decrease in a commercial price. And so there isn't a mechanical one-to-one, but it is certainly the case that folks who are in charge of reimbursement and revenue at providers do take into account where they can charge differentially based on the market dynamics, the percentage of their revenue that comes from different payers, et cetera. So I think it's a factor that everyone, that folks on both sides of the negotiation need to bear in mind, but probably trying to get the layer beneath that about like, well, what is the reason for the price increase? Don't talk to me about what Medicare is doing. Like, why do you need, what is your justification? What is your, why is the price what it is for my commercial product, irrespective of what's going on with other payers?
But I mean, and I think what Katie's saying is correct, but I also think it's important to note the tools that are out there now that is clearly showing the disparate impacts of what the commercial charge is versus what everything else is. If you look at the Sage Transparency tool or the break-evens that you're getting in hospitals, based on the publicly available information, understanding that maybe that's not the whole picture, but based on publicly available information, some of the hospitals in New York City should not be charging 400% of Medicare to offset their losses they're getting in Medicare and Medicaid. Medicare is supposed to be an efficient pricing mechanism. If it is, and let's assume that it is, okay, maybe you need more than 100% of Medicare, but you don't need 400% of Medicare or even 250% of Medicare. And I think especially when you start to look at things like the Lowndes study that came out yesterday related to the charity care deficits within New York City, if these hospitals are not-for-profit hospitals are getting the tax breaks they're getting, and yet you're still seeing the deficits between the amount that they're getting in tax breaks versus charity care, you don't need to then also jack up your commercial prices.
That's a really important point, and I think speaks to the like. I don't want to suggest that we ignore context, but it does remind me of things I say to my child, which is like, don't worry about what they're doing, worry about what we're doing. But there was a case, I'm going to get it a little bit wrong, and maybe one of my panelists can help me, but it was the Montana state employees who set a cap. Their commercial cap was something like 400 or 500% of Medicare, and it's still saved compared to what they were charging in the market without the cap in it. And that, I think, is undergoing some revision and tumult at the moment, but it does speak to like what is enough, and if Medicare is supposed to be efficient. And to your point, like even if it isn't, it's not that wildly inefficient. And I guess I'm just sort of, I worry that it becomes a distraction to what is the actual conversation that needs to happen, which is like, what is the justification for the price that you are charging me for the services that you are providing me and my panel, my enrollees?
And something else I would just add to that too. I mean, Cora mentioned like the some of the data on like the break-even point that's out there, and it like really shows that there is room to bring down what commercial payers are paying, and that is true even if you're assuming that hospital costs are fixed, which I think is like a very, that is a very generous assumption to the hospital industry. And what we really see is that hospitals that have a lot of private payers and they're more wealthy, kind of well-resourced hospitals, they are building to price, right? So it's not like other industries. We're seeing that costs are going up as prices go up, and there is room to bring prices down, even assuming that costs don't change. And I think there's also room to bring the underlying costs down as well. And so the one thing I would just say, like as a takeaway here, I mean, I think there's a lot of headroom to bring down the commercial rates, even like holding Medicare and Medicaid rates exactly where they are now.
So you guys kind of walked right into my next question, so you guys are great panelists, but it really goes back to the transparency issue, and right now we're operating almost in a black box. So this past January, hospitals were, required to post their clear, concise pricing and make it accessible to the public. So a question is, for the entire panel, is that the right type of transparency? And if not, what is the right type of transparency for insurers, payers, providers, and employer groups and members? So who wants to take that one first?
I have a very strong opinion, so I'll start.
Yeah, go ahead.
But welcome other people's point of view, obviously, as well. I think transparency is critical, and I think we need to be clear on, to your question, what kind of transparency and why. I think if you want to make tools available to consumers to help them understand the bill that they're going to have to pay and the costs that they have to confront, I think that is valuable. And as a healthcare consumer, I would appreciate that. And I think that is a completely different conversation than controlling healthcare costs. I am not interested in asking someone who has just been diagnosed with cancer to figuring out how they can also, while they're curing, hopefully, their cancer and going through treatment and dealing with the financial, mental, and emotional burden of that, if they could also, while they're at it, solve this decades-long intractable problem we've been having with our U.S. healthcare system. I think the value of the transparency initiatives is really much more for people like us on the panel. It's for geeks like me to take it and say, this is what the variation in cost is. This is what the price is. This is the extent to which utilization is contributing versus price. And it's so that plans like Cora's and like employers can use the data to affect change. But it shouldn't be put on the back of consumers, and the notion of, it shouldn't be put on the back of consumers, and the files and all of the information that's being put out there does need to be usable, but not to the average person. It has to be usable to me. Our nonprofit is solely focused on understanding healthcare costs and information, and it is exceedingly difficult for us to access and use the information that has been made publicly available. And we're real interested, and we've tried real hard. And so that says to me that it isn't achieving its objective. But I don't want it to get twisted and make people think like, I want the average Joe to be able to download a JSON file while they're on their way to chemo. Quick sidebar, I was at a panel meeting in DC that had like reps from hospitals, employers, and plans, et cetera. And a health system rep was talking about the health transparency, the hospital transparency files. And she said, I just think it is such a shame that when we're having a conversation with someone who's going through cancer treatment, that we also have to tell them how much it's going to cost. Like they just need to, deal with being cured. And I said, but isn't the problem how much it costs? Not that you have to tell them. Like, let's try to keep our outrage in perspective here. Like, it's not a problem that you have to tell them what it costs. It's a problem that it costs them as much as it does. So, sorry.
No, and I agree with most of what you're saying, Katie, because I don't think it should be on the backs of consumers to solve the healthcare crisis. And I agree that right now, the transparency data, we tried to download our own machine-readable files that we are accountable under the CAA for, and it broke our system.
Yeah.
So we have to trust that our third-party administrator who've said, yes, we've done this, we're testing it meets the needs. And you know what, we've checked the box. But it shouldn't break our system, and we have our own data warehouse, I have half my staff are in the data engineering and data analytics side, and it still breaks our system because it's not a usable data source. And so the fact that we have to go outside of the own data that's available to be able to analyze it is a problem, because it should be, but I think the other piece of transparency is that I personally can't share claim level data publicly, because my hands are tied based on my contract with the folks in this room and your contracts with the hospitals. And so I would challenge is that I think any transparency is better than no transparency, but I need to be able to say that I paid $2,314 for a colonoscopy at this place on this day, or $10,210 at this hospital at this place on this day. But I can't, because it violates data use agreements. And that's a problem. And that's a problem. And it's because it violates proprietary contracts between insurance companies and hospitals. And so me, as the bill payer for my members, I can't tell them what I paid. Fundamentally, that's the other piece of the transparency problem. Yes, we need transparency. But we, here on the panel, need the transparency more so than can the member go and Google 500 shoppable services and figure out which outpatient facility they should go to in the 5 miles from their house.
And that's a consistent problem that employer groups have been talking about and that you're hearing increasingly about. So I don't know if it's trending up or if there's just greater demand on transparency, but that's a very consistent theme.
So we've talked a lot about pricing. I want to jump to prescription drugs before we run out of time, because I think that's, you mentioned 21.3% of our spend is from prescription drugs. I think professional inpatient, outpatient range between 4.5 to 7.4. So, what are the factors that are at least that are being sold to the market are the driving forces behind the pharmaceutical cost increases?
That's a great question. I mean, I don't know is the answer, and I think it speaks to this transparency point, which is I don't know, and I don't think anybody really knows other than the pharmaceutical companies. I think the pharmaceutical market is an interesting one because intellectual property and patents and all of that play such a critical role in their business model in ways that don't throughout the system. And so certainly patents and trademarks and exclusivity, and they do a really good job about figuring out how to make the system work for them. How do I get an extended release which extends my patent? I think one of the challenges we have is rebates and coupons. Like, we don't even really know what prescription drug costs are in our data because that all operates separate and apart. And we just recently had someone come in because I was like, I don't understand drug rebates. Somebody please explain it to me. And I still don't really understand them. But what I do understand is that basically it's a whole system and structure and mechanism that was built up to get market share. And that's unusual and problematic, and I don't know how to begin to tackle that. I'm sure that my colleagues have a much better answer to your question than I do, but it is an area where I think opacity is really driving the day because it's nearly impossible to know what the drivers of the costs are, so it's impossible to design an intervention to address them.
So Corey, you just tackled this, so can you talk a little bit about your process?
I mean, I'm with Katie in the sense that I am seeing our drug costs go up, but our rebates go up greater than the drug costs, and you're like, great, I'm spending less money, but then there's fundamentally a problem in the system if that's how you have to spend less money. So no, I don't really actually think I can answer your question because I agree. I think there is, I think there is a fundamental challenge. The other thing is I think pharmacy is important, but when you're looking at where you're spending your money, we should continually go back to hospital pricing, and we should be talking about inpatient and outpatient hospital pricing, and that pharmacy and is a distraction to the larger issue.
I think the one thing I just pick up on, I think this goes back to your question about transparency, Brian, too. I think we have a lot of places in the healthcare system where it's just very opaque and we actually don't understand quite what is going on, and that really inhibits the ability of plans and purchasers to make good decisions. It really inhibits the ability to design smart policy, to address cost drivers. And I think in the pharmacy space, there's two places where more transparency would be really helpful. One is around what is actually the price paid. So what is the net price post rebates? I know there are concerns about kind of proprietary data with that, but I think even knowing the net price at like the drug class level would be incredibly helpful. And then I think the second area is around pharmacy benefit manager contracts and what is actually being paid there, both on the pharmacy side as well as on the plan side with PBMs. So I think there are a lot of places we've all highlighted of where we need more data. I think the pharmaceutical industry is one where there's particular need for that.
But part of, I think, what happens is a set of perverse incentives around public health pricing and the 340B program, which I'm a proponent of as an entity that has, as running entities that have benefited from those pricing structures historically, but there's a trade-off. It's like, we'll do this public health pricing over here, but on the other side, then we won't regulate pricing, and that's a sort of deal with the devil situation. And I think it is related to how the very opaque price structure on the non-regulated drug purchasing side of the house operates. And I think that has to be tackled specifically in the drug pricing discussion.
So any questions from the audience? We got a couple minutes left, before I throw my one last bombshell question. should just give me a microphone. Thanks. So this is for Katie to start. What insights do you have as to why prescriber-administered drugs are increasing so rapidly? Strictly unit price, 340B, associated office visit costs, so kind of related to what we're just discussing.
Yeah, I mean, I think it is a question worthy of additional exploration. I suspect that it is all of those things. But I also think, again, it comes back to financial incentives and the incentives on physicians to prescribe and to administer drugs, you know, to the extent that ASP plus 6 is how we're being reimbursed for those services. You just have an intrinsic financial incentive to increase costs, and any place that you have that is potentially problematic. But I think everything else that you've just described also comes into play. I think, again, there are consultants, there's whole industry. Every now and again, I get a little overwhelmingly frustrated with this, but there's just industry that crops up around every component of healthcare that is designed to profit maximize. And I don't suppose that's different from other components of society, but I find it really frustrating. And the transparency data, sorry, I'm veering, I'll come back. But the transparency data is another example of it, because you can't open the files and I can't open the files. There are startups backed by private equity and venture capital who can open the files, and they're going to open the files for you for a cost. And there's going to be a whole industry that builds up. So I guess this is a way of saying, the reason I suspect it's all of those things is because hospitals and providers pay consultants a boatload of money to figure out the ways that they can increase their revenue and generate maximum profit. And so to the extent that any of those levers help with that goal, I suspect that they're being pulled.
If I may, I'll add to that from the provider side, right? The prescriber-administered drugs are also partially rising in frequency because this is when patents sunset. The next generation of the drug, it's an injectable, and that's what's different about it.
That's a good point.
Right, and that is part of the issue here, and that's why in the HIV space, for example, the next generation is about the modality of delivery.
Good point.
So before I let the panel go, I'm going to pick up on Katie's movie reference from earlier. And, you know, City Slickers, obviously great. City Slickers 2, The Search for Curly's Gold, not so much. But on your piece about what's the one thing, I'm going to ask each of the panelists, if you had one thing that you would like to see done, what would that be? I'll start down with Eric, and we'll work our way up.
Okay. I think it has to be something around hospital prices. We've been talking about that a lot, but it is the big cost driver. And I think if I could only do one thing, and I will say, I do think it requires a suite of things, so I don't think we should just do one thing. But I think directly capping prices or limiting excessive prices in some way is what would make the biggest, most immediate difference. I mean, this is not a functional market. And we don't have to go in and price set and regulate prices, but I think we can say, past some level, prices are just truly excessive. We can debate what that level is. Is it 2 times Medicare? Is it 3 times the Medicare rate? But at some point, it really is just price gouging. And so I think directly limiting those prices would have the biggest impact.
Cora?
I would say the same thing, hospital pricing and understanding how to regulate. And it's probably not just hospitals, it's also, provider prescription medication and injectables. But it is some element of price regulation. I think I would like to think that we could do it without it, that that transparency would bring a more functioning market. But I think that there are too many burdens to actually make it a transparent market. And so I think that, I think it's going to come down to some element of policy regulation.
I agree, and for variety, and because I like kind of trying to get as close to root cause as possible, I would say that it is meaningful transparency, a suite of transparency provisions that include allowing you to have access to your data, but also having truly usable, transparent data. Not because that's going to solve the problem, but because I don't know where to set my prices at hospitals. I don't know where to set my caps because I don't know what's happening. And so it feels to me that even though the immediate impact will not be as great, and if I were going for size an impact, that's what I would choose. But because I think that would be a real signal of structural change coming if we could genuinely have robust price transparency.
Oh, I'm going to go way out in left field, literally, and say a nationalized healthcare system.
All right, well, thank you all very much. This has been an excellent panel. Brian, thank you for taking the time to moderate. Wendy, Katie, Cora, Erica, thank you all for your time. This has been informative. Please give me a round. Thank you. So originally our next panel discussion was going to start at 11 o'clock. We're going to push that back a little bit, give you a little bit more time with the exhibitors, the sponsor areas, the food. So we'll be back here probably a little bit before 11:15 for our last panel of the morning. So thanks, everybody.